Okay, we'll go ahead and get started and we'll let everyone else join in who's coming with us. I'm going to go ahead and share the screen for you and introduce myself. My name is Darian Laird, and I am the newly appointed Executive Director of the Global Coalition for Radiotherapy. And we are very excited about this initiative with the National Institutes of Health, working towards access to high quality medical imaging and radiotherapy. And I have been in discussion with Professor Pat Price, who is a GCR co-founder, as well as Ted Trimble, with the National Institutes of Health and the National Cancer Institutes about this exciting discussion. We've started to engage the conversation, not only amongst us that kind of initiated with World Cancer Day 2025, but also several colleagues who are having this discussion in other spheres around the globe. And we're excited to start bringing that conversation together in a centralized place and see where that goes in terms of engaging in this implementation science. And to start out, I'm going to pass it over to Professor Pat Price, who not only is a co-founder of the GCR, but is also our newly appointed chair of the board for the GCR. So Pat, I will let you go ahead and talk a bit about, and this is our agenda, which we sent over to everyone as well. And we do have, during the moderated discussion, a couple of people highlighted who, as I mentioned, we've engaged with quite a bit over the past couple of months to talk about some of the other discussions that are happening for both Lancet and oncology commissions. All right, Pat, I'll hand it over to you.
Okay. Thank you, Darian. Great, very exciting and very important next steps here now. So I just wanted to introduce what we've been doing with the GCR and our essential standards document, and where we've got and now the next step in terms of the implementation. So next step, Darian. So as you know, the GCR has been going for about 4 years now, trying to bring together a sort of global community of all the players, everything from industry to patients to all the professional disciplines. And we've done a number of initiatives. And this was over the last year. What we've been looking at is developing an essentials document so that within national control cancer plans, there is actually much more detail put forward about what should be in the radiotherapy sections of this. And we've got many colleagues very expert in their areas. We've worked on 5 different key areas over the last year. First of all, on the training and technical support, what is required of specific professionals and their knowledge and skills to provide this, then the quality and safety, that's in terms of the treatment quality and standards of practice, and then maintenance and service, from a lot of it, the machine manufacturers to encrypting there about, and that's often one of the things that's in lower and middle income countries, that is a real big problem. But what is the minimum standard for getting that safe delivery? Next slide. And then a piece on advocacy. I think we all feel that radiotherapy has never had enough advocacy. It's always an afterthought, partly because of lack of understanding, but we're really trying to raise it up absolutely in the forefront. So when people think about cancer plans, they should be thinking radiotherapy right from the start. And particularly as when cancer centres are built, usually you have to start with your radiotherapy. Once you've got your internet access and your transport and all the other infrastructure needed for that, then the rest comes as well. And then that links with the imaging infrastructure as well. So we feel advocacy is a really big part. And then, of course, absolutely fundamentally and leading on into the implementation is about data collection and data monitoring. We're uniquely placed in radiotherapy because we are a technology-based subject area where we can get data from machines. We did a huge amount of work, like in the Ukraine issues about trying to get remote access, all these things, amazing technology. But we need to monitor data and we need to collect it and we need to feed that back to improve. So that's our components of the essentials document. We're now getting to the stage of implementation. We did a soft launch at the end of last year, and now we're implementing. We've pushed this in the UK. We've produced our Towards World-Class Radiotherapy document for the UK, and Sarah Quinlan's here from Radiotherapy UK. In Sweden, there's a presentation to the Ministers of Health and Finance in Stockholm. In Ghana, a project led by Katie Wakeham, Professor Leach and Dr. Kofi about starting their data analysis, and then case study collection from Indonesia, working with the UICC, and culminating, we're now planning a publication of this in cancer control, which will be a radiotherapy supplement about these essential plans. Next slide. And so this is where we are. Then Ted approached us, great initiative he's been working on, obviously with the NIH and implementation. And now with this document, the essentials planning, we can now move to the next stage of the implementation, which is what we wanted to talk today. So there's the QR code there. People want to find out more, but now I'll hand over to Ted. And thank you, Ted, for brilliant initiative here.
Thank you very much, Pat. We're delighted to be able to move forward with you all on this initiative, which we see as helping countries and people around the world to have access to high-quality medical imaging and radiation therapy. I'm by training OBGYN and GYN oncologist, and so I'm a user and someone who has great respect for the importance of medical imaging and radiation therapy, in my case, for the treatment of women with gynecologic cancer. And I'm also pleased to see so many old friends or friends of long standing joining on this call, because certainly with, let's say, Hetty Resac and I have worked on medical imaging for cervical cancer for many years, and it's great to have her and Bill Small, Mary G, people that I've worked with for decades on these issues. Next slide, please. So the goal of this effort is to how do we ensure that people around the world, not necessarily those with cancer, those without cancer, get the best possible medical imaging, for the cancer patients, the best possible radiation, the best possible chemotherapy. So to do this, we know that we need to have a broad coalition, including, as Pat mentioned, the advocacy community, the healthcare workers, doctors, nurses, physicists, technicians. Industry is critical. Governments, the various relevant UN agencies, the academic community, the global health community. And then for the individual patient, we know that we need to have a timely diagnosis and staging. We need to make sure that we have insurance coverage so that the facility gets reimbursed for their hard work. We know that we need patient navigation. We need digital imaging data. We need to make sure that we improve the patient experience, and we have the appropriate follow-up and survivorship care. Next slide. So we also want to look to see how we can strengthen the treatment sites, make sure that we have reliable sources of electricity, as well as internet access is obviously key if we want to do real-time QA, QC, to share data. We need clean water. We need good service contracts for the equipment, supply chain for disposables. One of the big efforts we've identified really across hospitals and clinics is the need to have trained technicians who can fix the machines, earmark money for replacement parts, and to have transparency and accountability in general. We also want to make sure that we have, as I said, comprehensive stakeholder engagement, that we have real-time metrics and data evaluation. We know what patients are getting scanned, what patients are being treated in terms of radiation therapy. We need to have collaboration across health domains because, as Hetty and I have discussed, imaging is often kind of a stepchild or an afterthought, although it's critical for many areas of medicine. And we need to build the recognition for the importance of medical imaging and radiation therapy, as well as build a platform of financial support. So to implement this, we are going to develop some objectives, timelines, make sure that all the stakeholders are involved. We plan wherever we can to have high-level workshops at high-profile events so that we can facilitate the discussion, but also broaden the awareness of these issues. As Pat mentioned, we want to have clear deliverables including such things as draft standards, guidelines, implementation frameworks. And in terms of high-level workshops, we want to take the advantage of the World Health Assembly in Geneva later this month to organize a hybrid in-person and face-to-face meeting to bringing together all the constituencies we discussed to raise this at the highest levels. Next slide. So we've invited some of the global leaders in this area, Professor Hedy Risak from the United States, Professor Andrew Scott from Australia, and Dr. May Abdel Wahab from the International Atomic Energy Agency to discuss these issues. And so these are the discussion points are the ones we mentioned earlier, but I'd like to start with inviting Hedy and Andrew to talk about their work on medical imaging. Hedy, Andrew?
Okay, thank you, Teddy. It's really a pleasure to be here, and hello, everybody. Andrew, May, and myself were leading the Lancet Oncology Commission on Imaging, and really, with the help of Rifat, produced some very valuable data where, for the first time, imaging. I'm sorry, we don't have the slides to show you because sometimes it's easier to look at the numbers. But for the first time, we have shown that imaging, proper use of imaging, does impact patient outcome and saves a tremendous life. And if you can just pull up your slides and then complete that sentence. But also there is a tremendous return on investment. On every dollar that you spend, the return on investment is tremendous, $6 and plus, depending on the disease and the imaging modality. And those two factors, those 2 points are the points that really got everybody's attention. Industry and the government because of the return on investment, and societies because of the impact on survival. And radiation oncology and imaging many years ago were actually one specialty. There are still some of us that trained in both during residency, and then we split afterwards. And we heavily depend on each other. There's no radiation therapy, precision in radiation therapy today without imaging. So Andrew, May, and I think are really very happy to be here. Andrew?
Yeah, thanks very much, Hedy, and thank you, Ted and Pat. As Hedy's indicated, the data that we've been able to generate, assisted wonderfully by Rifat Atun and his colleagues at Harvard, did show, and just to quote a few numbers, that improving imaging access in low, middle, and high-income countries would actually, in conjunction with improved access to therapy, save 10 million lives over a 10-year period. And the return on investment, purely from an imaging investment, was $100 per dollar invested. As a consequence of this, we have been engaging not just with the International Atomic Energy Agency, but also with the World Health Organization. And part of the strategy that Hedy and I and May have been working on is to try and do probably something similar to what you've described, which is to have a resolution passed by the World Health Assembly. And we've been working with a number of countries to be the sponsor at the executive board of the WHO. We've engaged with the WHO themselves quite frequently. A number of us will actually be in Geneva at the end of this month as part of that process too. So I do think we're working towards a very similar goal in parallel, and it's wonderful to hear about your plans at this stage.
I'm not sure if May is on the call. May is so busy, and I don't really see There are so many of us on the call. But just would like to say that May and IAEA are very, very committed to helping, as you know, of course, radiation oncology, but the imaging community as well.
Now, question for Hetty and Andrew is: are there other domains in medicine that we should make sure that we have at the table? I mean, obviously, we need imaging to evaluate injuries, to evaluate, people with fevers, people with tuberculosis. I mean, what are the other medical disciplines that could be advocates for us in this fight to improve medical imaging?
So, Ed, it's not medical imaging, but I think we often forget pathology. We can have all the imaging you want. We know that from breast cancer screening, the relatively biopsy now with the help of AI and mobile devices can be relatively easily implemented, but we don't have pathologists. And I think it is one subspecialty I would really like to bring along because Ted, as you know so well, and so many people on this call, cancer care is continuum care. We are one team, and if we don't have some members of our team, the care suffers. So I would, in a way, bring in, because they also need equipment, and they need tremendous investment because AI is really, really booming in the area of pathology. And AI reading of regular histology slides is now a reality for many indications, FDA approved. There is a workforce shortage, and if we can bring a few leading pathologists with us, I think it would be very helpful.
I might also mention, Ted, to your point, is that medical imaging and nuclear medicine, which was the subject of our Lancet Oncology Commission, obviously has implications far beyond just cancer, which I think was what you're perhaps indicating. Once you've got the equipment, once you've got the infrastructure, once you have the workforce that's trained, it can apply in a number of other areas. So as part of our proposal for a World Health Assembly resolution, we are proposing imaging not just in cancer, but also in neurological disorders, cardiac disorders, infectious disease, and so on. And we've reached out to a number of organizations that are official non-state actors to the World Health Organization to get their initial support for what we are proposing for a resolution. So we're starting to reach out to other groups.
And Andrew, have the other groups been receptive to this, to that outreach?
That every single one of them so far said yes, they're supportive.
Yeah, great.
Actually, very supportive and almost grateful. Because alone, as a team, we're going to be stronger than either one of us alone.
Good, good.
And can I ask, in terms of the details of your resolution, is there anything from Ted's thinking about the implementation side that can add, or is it what is the scope of the resolution?
So it's a fairly dry document, as most of these things are, as you know, and it really just talks about the importance of having access and availability of imaging and making the specific comment of, some of the examples that we've generated with our commission. But the proposal is really to ensure that access to imaging is incorporated in universal health coverage. Right. That's the key parameter that they always look for these resolutions. It's up to each government then how they implement it. But when you get something from WHO as a bit of an imprimatur, that's probably the best we can do at this stage.
No, good. And in terms of implementing this then in terms of assessment, feedback and ping? How are there some shared learning with radiotherapy? I was wondering, Mary, you're on the call, not jumping on you, but Mary G, is there, do you think how much of a crossover and we can share with radiation and imaging in terms of the next step in terms of implementation?
Well, I think the two are intertwined, as Hedy said right at the beginning, and the two specialties sort of departed, and then I think they're coming back together, and there's probably a need to eliminate or at least lower the barriers between the different disciplines in medicine. Once you sort of put the patient's needs in the center, then I think we all want the same thing. So I think rather than thinking of what specialties need what, I think we all need to embrace this sort of patient-centered approach, which then means that we bring to the table all the elements and all the resources that are needed to provide optimal patient care and optimal cancer control. And I think it would be good to start with the bigger picture and then sort of say what is needed for specific clinical situations.
So, Pat, if I may add, and be shrewdly simple and honest, the reason for the resolution is that the imaging gets paid for. Because once the resolution is approved, then it becomes mandatory for the national health plans to include imaging and pay for imaging. Right now, even with mammography, sometimes there is a problem, but the PET-CT and all of this is not being paid. And we can have all the imaging equipment and all the radiation equipment that you want. But if patients cannot afford to have it, it's useless. So I don't know how many of you are familiar, but a few years ago, there was the resolution on childhood cancer passed. And it's for the very first time that the therapy for childhood cancer is being paid for in Africa, in low middle income countries. Before, one of the reasons for such a poor outcome, nobody could afford the therapy. So that's why the resolution is so important. It's really that people access recognition, but most of all, that it gets paid for by the national health plans.
Yeah, I agree with Hedy that the resolution will definitely help with ensuring that as universal healthcare is rolled out, it does pick up these important things. But we've certainly seen some lags, even let's say in cervical cancer treatment, where we have a resolution, but universal healthcare, as universal healthcare is rolled out, it is not necessarily covering all the costs of imaging and even radiation therapy for women with cervical cancer. So I think the WHO or the World Health Assembly resolution is the first step, and then we need to work with the regional offices and work as well as work with individual countries to have them look at their universal health care coverage and make sure that the both imaging and radiation therapy are paid for.
Can I just think about also when we're thinking pathology, it made a really good point, and obviously the AI there is really. I was just thinking in terms of systemic therapy. I see Paul's here from Roche International. I wonder if Paul, you had any comments about branching out further even into systemic therapy, or that interaction, particularly with so many radiation systemic therapy interactions.
Yeah. Thanks, Pat. And I like what one of the things you said was no precision care without quality imaging. But I think the point we might be missing, especially for countries, is the full return on investment for the continuum of care. And the more we segregate the portions, the unlikelihood that we'll get that benefit we are trying to achieve. my view is that the patient gets the full benefit of the outcome we are all envisioning if they can get the full package. How good is the MRI for cervical cancer in a country where there's no good surgery that can then do surgery in stage 1? So you can have a greatest MRI and you have your good staging, but if you can't get surgery, that return on investment, I think you've mentioned, doesn't hold in that country. So I'm of the view that systemic therapy, imaging, radiation therapy, we need to show the external system that oncology is a micro ecosystem in the healthcare, and it's not a point intervention. And I think that's the approach we are trying to take from our end. And I think, Pat, you heard some of these comments at the London Global Cancer Week, but we are trying to make sure that the payers who are usually the same payer, and I totally agree, we want governments to pay for these services. We want the funders to look at this in terms of an outcome. Return on investment is a great outcome if you look at the UHC approach from the World Bank. But if they see it as small little pockets, we might confuse the single payer that we're all talking to.
Yeah, no, really helpful. And Matt, Hiki, I wonder if I could bring you in here, because you've been doing some work on quality assessments, really, with all this. How might this add to the mix?
So I'm glad Paul's just brought all that up. It's a perfect segue, Pat. Fundamentally, turning quality into a metric that a payer is going to understand is a bit of a challenge. So, Paul, you were just talking about keep looking at the continuum of cancer, not siloing things. Payers, government or insurers are often looking at multiple interventions coming at them left, right, and centre around giving some meaningful clinical outcome, but often it's not directed or presented in a way that a payer would understand, who are particularly looking at health economics and a return of investment over a population. And particularly when those things are fragmented across a clinical pathway, it makes that presentation very difficult. So if we can bring that into a translation of quality of service delivery across a care pathway with XYZ intervention associated with that care pathway, particularly if we're looking at what a total outcome might look like, then we've got a better opportunity to translate that to cost of life to a payer. And that's ultimately what they're looking at, is how much is this intervention going to improve the life of this individual, at what cost, over what time, and how am I going to get a return of investment and reduction of risk into my fund, if you want to look at it that way. Quality equals better outcomes in theory. It's just we haven't done a very good job across the industry in presenting that very well to a payer, who are fundamentally investors, and that's the way they're looking at it. So translating clinical outcome to cost, very important.
Yes, it's interesting. I was thinking back to World Global Cancer Week, London Global Cancer Week, where it ended up in that workshop deciding it's the finance ministers we need to talk to, not the health ministers.
Well, exactly. And I'm glad you said that, because coming from my world in insurance, where I was as a head of cancer, doing a clinical assessment on an intervention, or even a pathway or a change of policy, is one thing. Doing that with the chief medical officers, etc., is one language you have to speak. You then cross the hallway and talk to the finance officer or chief commercial officer, who has to sign off that budget. And it's a completely different discussion, completely different language. So I think if we're going to present data which pushes the innovation, etc., forward, we've got to understand the languages and who we're targeting, and the languages that we need to translate clinical outcomes and clinical benefit, translating to a return of investment and a financial metric.
No, that's really helpful input. And just again, another sideways, Jeff, lovely to see you from Astro. In terms of Astro and advocacy and input from there, what's your thoughts about what else needs to be added to the mix for this implementation?
I mean, I think we're covering the right bases right now, and I think, again, as you know, the U.S. is in the middle of an election season too, so we have to think about kind of who our partners are going to be, kind of who that's going to. Sadly, it will make a difference, kind of who's on our side too. So I think we have to think strategically about that sort of alignment as well.
So, Pat, if I may just answer Paul's comment. Paul, we did look at continuum of care in our Lancet, and then we put 2 points: survival with continuum of care, all the surgeries, pathology, everything, and then what happens if you don't have imaging and what happens if you have imaging. So it was imaging centered. So we really put imaging, what happens, as well as quality. So for the next call, we'll be happy to show you the data, but we did look at the continuum of care with and without imaging and impact on outcome, as well as impact on return on investment, as well as we looked at the quality of care.
No, thanks for that, and I'm glad you brought that up. Maybe I'm referring to Matthew. Actually referred to this. We have the cervical cancer elimination strategy, which has been signed off by all member states. Last year we had the diagnostic resolution signed off, and in retrospect, we had a missed opportunity to sort of table some of these in the same kind of messaging. One of the messages that recently has been of importance, I think, to the payers when you look at the World Bank, has been what other services benefit when you have a very good cancer continuum? Because cancer is not a disease, it's multiple diseases. And if you talk about imaging, trauma is one of the biggest NCD in a lot of countries. So if you can get good imaging, then you sort out trauma. What's the return on investment on trauma? If you sort out your diagnostic, which was resolved last year, right? Resolution was passed last year. What other elements, when you talk about preparedness for pandemics, when you talk about infectious disease, the common cause of infection in a lot of these LMIC countries? So you're talking about a lot of systems in the healthcare sector benefiting from a single pathway called cancer. So I think what I'm trying to bring to the table here is, how do we ensure that the next concerted effort to get a resolution is actually broader than siloed as has been the last 2 to 3 cancer resolutions in inverted commas. So I think it's extremely important to put in imaging. I think it's one of the most common cause of delays in the LMIC. Having worked in the LMIC country, diagnosis was sometimes 9 months delay. Once you get a diagnosis, then you've got another 3 months delay waiting for a CT scan, which sometimes was a 64 slice instead of 128. So they're extremely important, but I think we have an opportunity to sort of combine our efforts into a single message.
Yeah, I agree with Paul, because certainly the diagnostic resolution, which passed last year, was across diseases and emphasized the importance of strengthening laboratory pathology and imaging and diagnostic pathology at the same time, so that you can evaluate, every person who comes in the door with an illness or with an injury or with cancer. So I think we have to convey that message that we want to strengthen its health system, strengthening kind of writ broadly, which obviously has benefits for cancer, but benefits for many other diseases.
Ted, did we want to talk a little bit about data and feedback? I know Tim Hanna couldn't make the call today, but what is our thinking, and again, of the people who are on, in terms of, again, because with imaging and radiotherapy is tech, it's AI, as Heidi was saying, it's we should be able to be really good at data and sort of even extracting data remotely. And how do you see that, and what are the barriers there for creating a structure so data is constantly collected and fed back and used appropriately?
Good questions. And maybe I'll ask Mary G if she's on the line to
Mary had to pop off to another meeting.
Oh, Mary had to pop off. Okay. Well, and please, if you are interested in making a comment, please raise your hand or write something in the chat, because we want everybody on the call to have an opportunity to contribute if you would like. Certainly, Pat, as you mentioned, I mean, data is critical, both the kind of the end data, in terms of patients evaluated, patients treated, if they have cancer, did they get the right treatment? Are they, what's the 2-year survival? What's the 5-year survival? But also just the We know now if you have internet access, you can do real-time QA, QC on your imaging. You can do centralized review of images so that you don't have to have a radiologist in every site. You can do centralized treatment planning. You can have
pathology as well.
you can have pathology. Certainly, there are good examples there, and I do want to mention that we're already working with the American Society of Clinical Pathology and UICC to make sure that what we do aligns with their efforts to improve pathology. But we really need, I think, to make sure that that we have the electronic structures in place so we can do the real-time QA, QC, both for imaging and radiation therapy, so that we can integrate the data from imaging into the treatment planning, as Lawrence Court and his group and MD Anderson and some other groups are already doing. So I think data is a critical piece of things.
Do raise your hand or shout if one needs to say. I know some of you are on camera now. Ted, do you think we need to for data? Do we need other parties in? Is this somewhere whereby the Microsofts of this world or Googles can be really charged with come and really get involved and help us with this? Or do you think we've got enough capacity within the imaging and technology ourselves?
Well, I think
no.
we need to. Yeah.
Did you ask me? I'm sorry.
Yeah, Hetty.
Did you ask me?
Yeah, sure, Hetty.
Oh, okay.
Absolutely.
Yeah. No. Partnering with, for example, Microsoft and GPT-4. Amazon is trying, Ted, to your question, Amazon actually put aside a very nice investment to develop a global platform that would be able to share, they said free of charge, imaging, pathology, all the images, not just radiology, all the very strong platform. I recently didn't hear from them. We used to have regular meetings and they stopped. So I don't know what's happening right now, but there was a huge investment by Amazon in that. And I know Microsoft and GPT-4 and Peter Lee are trying very hard to have a greater global presence. So Pat, answering your question, without industry, but a really strong industry in that area. Epic in the United States, Epic is absolutely huge and making a big difference in electronic records and organization. I would absolutely say without them, we are not going to succeed.
Because then that completes it full circle. Also, can I just ask, is anything being done or people have knowledge of the regulations around that? I'm just conscious on a very simple, basic level in the UK, we have an NHS. It should have been easy, but just to get to Electors Pro now, so we could get everything data in the cloud for peer review, we had to have a legal agreement with every single trust. Is there any work being done about getting a safe healthcare space where you're not going to get bogged down with regulations all the time, and then that's going to kill it? Does anybody know where things are there?
Yeah, I do know where. The reason is every country has different regulation, and basically Amazon just said, no, they're going to offer the tools and it's up to us to solve the problems.
So yes, because I wonder whether that needs to be addressed with some, because it's not something we often do, but that Ted, in terms of our bits of the jigsaw, that is one too. I'm conscious that we had again minor example, but when we were looking at the Ukraine task force, when trying to transfer plans to other countries, the solution there, which it was actually Varian, the company, helped us with, was to get sort of consent that was agreed amongst the EU to actually have the individual consent to move this, and one neat solution actually solve that problem. So I think there are solutions, but it's just kind of, it's nobody's job really. We don't have these regulatory people that are thinking about that. Anybody got any thoughts on that?
Well, I agree. We need to bring those people to the table. I'd like to invite Joanne Manrique, who runs the Center for Global Health and Development, to comment. And Joanne and I have been working to develop a kind of a broader women's health and economic development network that we think might be able to provide some of these wraparound approaches. So, Joanne?
Thank you, Dr. Ted. So it's a pleasure to meet everyone. One of the things that, as I was hearing all of you speak, is the financial need, the financial gaps in some of the work that needs to be done, both at the pediatric level for oncology, but also in terms of, the radiation and the different technologies such as AI that could be used in pathology. One of the things that we do we house the Women's Health and Economic Empowerment Network, which is a group of private equity firms, women philanthropists, foundations, and investors. And I always say to people, it's not lack of capital, it's how you're deploying the capital. So at hearing you speak, I think a little bit of what we could assist with through the Women's Health and Economic Empowerment Network. And Dr. Ted, thank you for being co-chair, is really looking, at the workshops that identify some of those financial gaps that are needed along the patient referral pathway, and who is best positioned to finance some of those gaps. Because sometimes people don't know until they're asked. This is your gap, right? So some of our equity firms, yes, they're making investments that are on hospital infrastructure, but you can tell them, look, reposition your investment here, which we've done in the past, because this is a location where we have machines, but they need better, electricity, or they need more renewable energy. So it's a combination of talking to those with the best capital allocations. And one of the things that we've been working on with Dr. Ted is a technical assistance facility that could really look at those gaps in some of the infrastructure needs alongside. So we look forward to working with you and hopefully seeing many of you in Geneva. We'll be having a follow-up through when on financial gaps. So thank you. Back over to you, Dr. Ted.
Thank you, Joanne. And certainly one of the things I've been learning both in my global work on cervical cancer as well as the discussions with Joanne is the importance of bringing the right financial partners to the table and being able to, as Matthew was mentioning, you have to be able to speak to the finance minister and then an hour later to the health minister, and they speak different languages, and you have to make your pitch in different ways to get both to sign on to support your activities.
If I may, I wanted to just, sorry, I think Fabio put up his hand quicker than me.
Fabio, yes, and then Paul. Fabio?
Yeah. Just getting back to the point of data and how we organize efforts to bring data, analyze the data in the best way possible. So a way that we should be doing this is actually developing data stores where we can use AI techniques to answer questions and to analyze this data. So the data never leaves the institution. So you can actually have the data in the cloud, and researchers, QI people can from any other places. We create a consortium, and then you can log in, and actually the data is still on that institution. So it's a way of going around the laws and going around regulations and being fair and honest on how you use the data. We have been using that a lot in imaging for federated learning. So we do federated learning. You can have 200 institutions. The data never leaves the institution. We create the algorithms, we validate it, and then we are able to make something that is externally valid. And adding to those points, it's essential that we have industry in, because that was the only way that radiology was able to grow on AI and machine learning, and ophthalmology as well. There's a big example of partnership of Google and ophthalmology in the UK. And one thing that we might need to develop is actually a document to make sure that everybody knows how to create and develop what we call fair data. findable, accessible, interoperable, and reusable. So I think the best way will be to create a data culture in radiation in imaging, so we can leverage those data in the future.
Oh, some great points there, Fabio. Thank you. That's fantastic. Great. Paul, you were going to say something.
Yes, I think I wanted to, first of all, appreciate Joanna's point, which I think is one of the challenges we face in the oncology space. Capital has remained agnostic for time immemorial, so whoever allocates a lot of resources wants a return on investment. And in the healthcare space where we are fighting with this, we're fighting for the same share. There's very good examples from the communicable disease space where returns have been shown. And one of the examples is HIV. We have seen generations being saved from extinction, which has been written about because of mother-to-child transmission investments. I think we need to understand that the baseline of the people that we're approaching to fund some of these initiatives, that's their baseline. They understand communicable disease, they understand point interventions with a return on investment, HIV, malaria, TB. You can calculate this very easily. And when they allocate money, the return is almost immediate. If we can translate that for them, and you've clearly put it very well, finance ministers and ministers of health speak different languages. One speaks for an outcome, and they're really sold on that in Ministry of Health. Finance is, here's $1, how much do I get in return? So I think understanding that there's capital, which we saw with COVID, capital somehow showed up on our doorsteps, and we controlled that. We need to use that same similar kind of energy in oncology, and hence the continuum of care, complete understanding of end-to-end. One of the things I was thrown at by an individual in the World Bank not long ago was, how much have we got out of the Cervical Cancer Declaration so far? So we need to work on that as this kind of community to start showing them examples of what they have got out of that so far.
Yes, and I think examples is really good. Can I just make one other point? I was conscious what we were saying about making it patient-centered, and then that's things. I was wondering, Sarah, if Sarah Quinn and I could bring you in from the patient. Sarah looks after Radiotherapy UK, a charity in the UK. We haven't talked much about patients now and their voice. I'm conscious that looking at the UK, when we moved on and prioritised cancer a lot in about 2000, it was the patient voice that did it. So how much are we needing that patient voice, and how can we add that to the mix, particularly internationally, do you think?
Yes, I think as Mary G referenced earlier on, the starting point of all of this is the patient, and then what happens around that patient to provide the best outcomes. So, I mean, that's our starting point in all of our work within the UK. Whenever we create things like the world-class vision document that we've just produced, to kind of show how you get to world-class radiotherapy in 10 years' time. Because like many other people, we're struggling with the government at the minute that doesn't really have any long-term planning in place. And what we're trying to do is show some blueprints so that there is something, whenever a sitting government decides that this is the way forward, we can just hand it to them and we can move and we can start to implement. But key to this is the patient engagement. And I think that, we have so many patient advocacy organizations throughout the world, and it's that piece about coordinating them. But this is happening clinically. Then we also need to almost have a parallel stream where we have the patient voice coming through as well. Because Pat, I know you referenced earlier on about the examples are really important. The examples are what all of this innovation, data collection can do for a patient. So we need the patient at the heart of those examples as well, and that, as we know, is what moves governments. Whenever you get your patient voice, whenever you have your patient advocates up there standing and they're pressing hands and they're in Parliament. So I would always say any work in this field needs to be centered around the patient, but also bring patients with them, as in they need to be in the room, not just being talked about.
Oh, no, thank you for that. Exactly. I'm also noticing some chat in the chat between Matt and Fabio. That's good. Obviously, you're twigged there completely on the data and the analysis. Ted, anything we've missed now in terms of people that need to be involved, lateral thinking we haven't done. We've got these fantastic group of people here now just for another 8 minutes. Anything we've missed in terms of, because what we should really do now is try and pull something together for the meeting you've arranged at the World Health Assembly to take that sort of next step. Is there anything, do you think, we're missing? Or anybody, open the floor now, anybody who's, we haven't mentioned anything? Think laterally now, yes.
Well, we definitely talked about the importance of having the pathologists involved, and that leads into what Paul mentioned in terms of the diagnostic pathway resolution that was last year. So I think we need to look closely at that and just see if there's anybody else that we're forgetting. We certainly have been talking about the data, and Joanne texted me about inviting the Google and Amazon to our meeting in Geneva later this month. I think one of our goals was to see how we could improve the patient journey. So I think we do need to carve out some time for looking at the challenges for patients in terms of getting access to high quality imaging and radiation therapy, because we know there are delays. There are often co-pays. Patients may have to sit around the hospital for 6 hours before a scan or a treatment. How do we make sure that the patient, who is at the heart of all this, actually is treated well, and his concerns are addressed. So I think we've got a number of issues that we need to make sure that we remember as we get together. So perhaps as part of our minutes from this call, we'll start to divide up the list of topics for follow-up, acknowledging that they're all interconnected. So because we do need some topic-specific working groups, but we also need to make sure that those working groups actually talk to one another, because it is a holistic picture. Before people have to leave, I do want to reiterate that we plan a next kind of virtual and in-person meeting on Tuesday, May 28th in Geneva. And thanks to Joanne and her team, we've got a room reserved at the Ritz-Carlton Hotel de la Paix. And so we're aiming for 9 to 10, although it can go a little bit longer on that day. It will be both in person and virtual. So Darian, if people want to attend, can they respond to you? Who do they respond to?
I will. I'll give everyone some, and thank you, Ted, and everyone for contributing to this discussion. We'll have a little bit of homework for everyone. We will follow up with a recording of this meeting and some follow-up questions and next steps in terms of gathering some engagements, working towards, as Pat mentioned in our, initiation of the radiotherapy essential standards, we have figured out a system to get together working groups to make sure that we are, as Ted mentioned, not just discussing in silos, but having a lateral conversation about what needs to be happening next. So we'll ask for your engagement, as well as reaching out to your network. This is why everyone on the call was involved and invited, because we also know you have a lovely network within your expertise and your spheres. We want to make sure that we have that patient voice, we have the engagement from pathology. So let's take that as a next step as well. And we'll follow up with information how to RSVP to this event as well.
Great, lovely. So Ted, would you like to close us off then?
Well, I think we really want to also ask people on the call to tell us when are the upcoming meetings where there'll be a nucleus of people who care about these issues that we can convene, because it's nice to actually meet people in person. We do as much as we can virtually, but we also want to take the opportunity where we can be in the same room to get to know one another better. So we obviously have identified this time slot during the World Health Assembly, but we know that ASTRO, for example, meeting is coming up the end of September. Pat mentioned the London Global Cancer Week. So please tell us about other opportunities where you think that we'll have a kind of a critical mass of people who care about medical imaging, who care about radiation therapy, who care about global health, that we can physically be in the same space with a virtual option as well. So,
Jeff, Astro, September the 29th. Thank you.
Perfect. Well, we will be in touch with everyone. Thank you so much for joining. Thanks for your contributions in the discussion. And Hedy, I know you mentioned at the beginning that you would love to share some of the data from the work that you're doing with the Lancet Commission. So if you do have other information that you'd like to share that would go out in the follow-up email to everyone that's on this list, and that's a call for anyone, please do send that across as well. And thank you all and have a lovely day. Thanks for joining us.
Thank you.
Thank you.
you.
Thank you.
Bye-bye.
Thank you.
Thank
Bye-bye.
you. Bye.